Welcome back to the second episode of Back to Bones, Orthopedic Legends Reimagined, the series dedicated to exploring the lives and innovations of the minds that have transformed orthopedic surgery. Today, we delve into the extraordinary story of Doctor Masaki Watanabe, known worldwide as the father of arthroscopy. Welcome, Mr. Watanabe.
It is a great honor to be here today at Back to Bone Orthopedics Legend Reimagined. Being recognized as a legend in orthopedics deeply moves me, especially knowing how much this field has benefited from the work of so many extraordinary colleagues. I am ready to share my story, my ideas, and the lessons I have learned along the way. Thank you for this wonderful opportunity.
Dr. Watanabe, how did you transition arthroscopy from a diagnostic tool to a therapeutic one? And can you share specific examples of early procedures that help demonstrate its potential?
The transition from a diagnostic to a therapeutic tool was a natural progression for arthroscopy, particularly as the needs in Japan shifted after World War II. Tuberculosis, once a common condition we studied with the arthroscope, became less prevalent. However, knee injuries from industrial accidents, traffic incidents, and sports were on the rise. This change in patient demographics created an opportunity to explore arthroscopy's potential beyond diagnostics. One of my earliest therapeutic applications involved a horse. A horse society approached me to investigate a talar chondral defect in the animal's ankle, which they believed to be congenital. During the procedure, I discovered that the horse's ankle was anatomically similar to a human knee, albeit upside down. This case was a fascinating confirmation of the versatility of arthroscopy. In 1955, I performed a pivotal therapeutic arthroscopy on a human patient, removing a xanthomatous giant cell tumor from the suprapatellar pouch. This procedure was recorded and is widely regarded as the first recorded arthroscopy on a patient. It demonstrated that arthroscopy could be used not just to observe, but also to intervene surgically, paving the way for its acceptance as a therapeutic tool. These early successes solidified my belief in the broader potential of arthroscopy.
Did you encounter resistance from Japanese or international colleagues regarding the adoption of arthroscopy as a diagnostic and therapeutic tool?
Yes, I encountered significant resistance from both Japanese and international colleagues when introducing arthroscopy as a diagnostic and therapeutic tool. Many initially viewed the technique as experimental and impractical. In Japan, some colleagues questioned the utility of arthroscopy, citing the limitations of the technology at the time. The quality of images, restricted field of view, and the need for specialized training made it difficult for many to see its potential. For example, when I developed the NUM-21 arthroscope in 1958, some believed that traditional open surgical methods were more reliable and easier to perform. Internationally, the resistance was equally strong. When Dr. Robert Jackson introduced arthroscopy to North America after studying with me, he faced skepticism and even ridicule from his peers. Many surgeons were deeply rooted in traditional approaches like arthrotomy and were reluctant to embrace a minimally invasive technique that seemed complicated and unproven. Despite this, Jackson persisted and demonstrated the technique's benefits, ultimately paving the way for its acceptance. A specific example of this resistance occurred when Jackson presented arthroscopy at an orthopedic meeting in North America. Many attendees were doubtful, questioning whether such a method could ever replace open surgery. However, as cases like my first arthroscopic meniscectomy in 1962 showed faster recovery times and reduced patient trauma, attitudes slowly began to change. These experiences taught me that innovation often faces initial skepticism, but with persistence, evidence, and collaboration, it can eventually transform the field.
How do you think the evolution of arthroscopic visualization technology, with systems that allow for seamless angle adjustments and expanded fields of view, has impacted surgical procedures compared to your early arthroscope models?
One example that comes to mind is the first arthroscopic meniscectomy I performed in 1962. The patient was a 17-year-old basketball player with a torn medial meniscus. Using the NUM-21 arthroscope, I had to carefully position the scope to view the affected area, which required precise control and patience due to the fixed angle and narrow field of view. Modern systems that allow seamless angle adjustments and expanded fields of view would have made such a procedure far more efficient and comprehensive. Switching between 30-degree and 70-degree views, or using an ultra-wide field, enables better visualization without repositioning, enhancing precision and reducing the need for additional portals. These advancements fulfill the vision I had for arthroscopy, improving visualization to make minimally invasive procedures more effective and impactful for both surgeons and patients.
Dr. Watanabe, it has been an incredible honor to have you with us today. Your vision and dedication have truly revolutionized orthopedic surgery and continue to inspire generations. Before we say goodbye, is there a parting thought or a piece of wisdom you'd like to share with us?
Thank you for this wonderful opportunity to share my journey. I am deeply touched by the continued impact of arthroscopy on modern medicine. As I once said, the real voyage of discovery consists not in seeking new landscapes, but in having new eyes. Arthroscopy has given us new eyes to see and treat the human body with precision and care. May we always strive to innovate, improve, and serve our patients with the same spirit. Thank you, and farewell.